We have the privilege of having Dr. Subhas Banerjee from Stanford speak with us today. Really doesn't need any introduction, but he is a professor of medicine and GI and hepatology at Stanford University, director of endoscopy there, and really on the cutting edge of evolving GI technology. He was the chair of the GI Innovation Task Force at ASGE. And as someone myself who performs advanced endoscopy, it's very interesting to see all these new techniques and videos on how to remove these difficult polyps or these really complicated procedures. But what we don't see a whole lot of is the complications and risks of these and how to manage those complications that undoubtedly occur when you undergo these challenging procedures. So we thought an interesting topic would be to see how Dr. Banerjee minimizes complications, and when they do arise, how he addresses them. So I'll let you take it away, Dr. Banerjee.
Cyrus, thank you for that kind introduction, and thank you to the board for inviting me to speak today. I'm hoping you'll give me privileges to share my screen. Is that coming across okay? I can't really tell.
Yeah, we can see everything very well.
Great. So time's short, so I'll just get going. As you all know, endoscopic mucosal resection has really transformed the approach to the management of large polyps and has saved innumerable patients the need for surgical resection. However, it's also associated with adverse events, and my remit today is to talk you through managing these complications in your day-to-day practice. Several important studies have been published over the last year or two, which are helping make the various aspects of EMR much more evidence-based. It's more of a science today than an art. My disclosures. So these are the complications you can expect if you make EMR part of your endoscopic practice. There will be patients with non-specific upper abdominal pain of unclear etiology, patients with a clear-cut post-polypectomy syndrome. Bleeding is going to be the biggest part of your adverse events, accounting for some 8 to 9% of your patients. And the most feared complications, of course, perforation, which is happily rare at around 1 to 1.5%. So this old adage, prevention is better than cure, is ascribed to Desiderius Erasmus, a Dutch philosopher circa 1500 AD, but it remains very true today. So as Suraj mentioned in today's talk, I'll also touch on what you can do to prevent, or at least minimize the risk of experiencing adverse events. So first we'll discuss the patient who is experiencing pain on recovery from a long and difficult EMR. And you examine him and he's all distended with air. This may wind up being nothing, but the concern, of course, is that you might have a small perforation. And this kind of patient will impact flow in the endoscopy unit, as the patient, he or she, will occupy a recovery bed for a much longer period of time and will require at least an abdominal X-ray and perhaps even a CT scan. So what can you do to minimize this kind of situation from arising? Michael Bork's group in Australia many, many years ago showed the benefit of switching from air to carbon dioxide for chronic insufflation for EMRs. And they showed that use of CO2 was associated with a 62% decrease in post-procedure admissions from 8.9% of the EMRs down to 3.4% of the EMRs. And this effect was largely ascribed to a marked reduction, over 80%, in post-procedure admissions for abdominal pain, from 5.7% down to 1%. So if you are doing EMRs, you should very, very strongly consider switching to carbon dioxide for insufflation. While we're on the topic of equipment, we should touch on what kind of current settings we use in our electrosurgical units. This randomized study from Heiko Pohl et al. Looked at the impact of adverse events with the use of Endocut versus forced coagulation settings on your Irby machine. In other words, the yellow pedal versus the blue pedal. And they found no difference between the two. So overall severe adverse events with the Endocut setting were 7.2% compared to 7.9% for the forced coag setting. A more detailed look at individual adverse events, both immediate and delayed, including bleeding, perforation, Abdominal pain in the post-polypectomy syndrome, again, showed no significant difference. So bottom line, stomp on the herby pedal that makes you happy. Let's talk about the post-polypectomy coagulation syndrome. This is seen in about 0.5 to 1.2% of EMRs. It has been ascribed to full thickness thermal injury to the colonic wall, resulting in localized serosal inflammation and peritonitis. Patients typically present with fever and localized tenderness, developing within a few hours to up to 5 days after the procedure. And this is typically associated with an elevated white cell count. Sorry, the slides are going backwards. Reassuringly, the abdominal films show no free air. If you get a CT scan, this is what you often see. You get mural thickenings. This is a polypectomy in the ascending colon, and what you'd see is marked mural thickening, which can be quite extensive. You can see the colonic wall is thickened all across the cecum and ascending colon. And there's often adjacent fat stranding, but there's no extramural air. The management is typically with IV fluids, antibiotics, analgesics, and bowel rest. What can we do to prevent this? Well, consider cold snare piecemeal EMR, at least for the smaller to medium-sized polyps. So this retrospective review from 5 Australian academic hospitals looked at the results for cold snare piecemeal EMR of 204 polyps, the mean size of 25.5 millimeters, using usual EMR techniques, but substituting a cold snare instead of the usual hot snare. The overall adverse event rates, as you can see, was 5.5%, which is very decent. And again, this is predominantly related to bleeding, intra and post-procedural bleeding. Importantly, they saw no post-polypectomy syndrome and no perforations, given the lack of any thermal injury to the colonic wall. So I'm going to spend a little time on bleeding, as this is going to be a commonest complication. To minimize the risk of, skipping slides, sorry about that. So to minimize the risk of intraprocedural bleeding, a lot of people use epinephrine diluted in 100,000 and mixed in with the lifting fluid they're using. They're both people like this and people who dislike this. A lot of people want to know if there's going to be bleeding so they can fix it more permanently. Fortunately, intraprocedural bleeding is rarely serious. The management options include epinephrine injection, snare tip soft coagulation, use of a grasping coag forceps, again in the soft coag setting, or endoclip placement. The main problem with endoclip placement is it may interfere with resection. And so if you have a large polyp, you're mid-resection, you may want to avoid placing a clip that's going to make your task more difficult subsequently. Things to avoid are argon plasma, which may not give you coactive coagulation, and bipolar probes, which may potentially extend the depth of tissue thermal injury. So here's a video of snare tip soft coagulation. You want to set your electrosurgical unit at the soft coag mode in your blue pedal, typically effect 4. You stick out the tip of your snare, very lightly touch tissue, and stomp on your pedal. And this stops bleeding from small vessels quite effectively. So for larger vessels that may need more coactive coagulation, a coag grasper is a great choice. Once you located the vessel, you grab it with the device, which is kind of like a forceps. Close the jaw around the arteriole. Again, with the RD machine in the soft coag setting, a couple of taps of the blue pedal will usually fix the problem. And finally, the endoclip. If the source of bleeding is not clear, the water jet usually reveals where the bleeding is coming from. So it's quite useful as you get your clip opened out to, again, pump a little water, make sure that the jaws of your clip are precisely across the vessel. It's useful then to close the jaws, but before you deploy the clip, to wait for a few seconds to ensure that the oozing has stopped. And as you can see, it has here, and that then allows you to deploy your clip. Again, not my favorite choice because it does impact the ability to finish the EMR easily. So moving from immediate intra-procedural bleeding to delayed bleeding, what can we do to minimize these risks? Should we be placing prophylactic clips? There are a lot of conflicting older studies out there with regards to potential benefits of clip closure of EMR sites. And so there's always been this need to balance the cost of the clips and the increased procedural time that's involved versus the expenses associated with delayed bleeding, the ED visit, readmission costs, costs related to transfusion and to repeat colonoscopy. But there's been very little definitive data to help us with this decision making. So what's an endoscopist to do? Well, it helps to know the risk factors for delayed bleeding. So this large multi-center retrospective study from the Netherlands looked at this issue. The strongest associations with anticoagulant use or platelet aggregation inhibitor use over the last week before the EMR, with odds ratios of 4.72 and 2.86 respectively. This was followed by increase in polyp size and proximal location of the polyp. And more recently, this large prospective randomized controlled trial confirmed that clips do decrease bleeding following EMR of proximal polyps. So 919 patients were randomized in this study. All of them had large non-penetrative polyps measuring at least 20 millimeters. And they're randomized to receiving clips or to the control arm that received no clips. Post-procedure bleeding was seen in 7.1% of patients with no clips compared to 3.5% of patients who were clipped. Now, subgroup analysis indicated that this effect was almost entirely due to the benefits of clipping in proximal polyps, where the rate of bleeding is 9.6% in the control arm compared with 3.3% in the clipped group. Subsequently, two further RCTs have confirmed these findings, as has this meta-analysis also published in Gastroenterology. Again, if you look at the risk ratio line, what you're seeing is a beneficial effect of clipping for proximal polyps, but not for distal polyps, and again for larger polyps, but not for smaller polyps. And more recently, this decision analytic model study has also shown that routine clip closure of large polyps was cost-saving to payers following resection of large polyps. So the authors were able to demonstrate a cost savings of around $287 following clipping for all large polyps compared to no clipping. And this was based on assumptions regarding the rate of rebleeding and the costs associated with clipping and so on. And this cost savings was driven largely by prophylactic clip closure of large right-sided polyps, where a gap of $434 was seen. No cost savings were seen for just left-lung polyps. So to summarize, I think the evidence is now overwhelming that we should clip following EMR of proximal large polyps. For large distal polyps, we can take a case-by-case view, depending on patient factors. And patient characteristics that may drive a decision to clip include the need for resumption of anticoagulation or antiplatelet agents, the presence of significant comorbidities that may make it difficult for that particular patient to tolerate a bleed, and for patients who live in remote areas with poor access to medical care. And so if you do have a patient who comes in the bleed, how do we manage it? More or less straightforward. They get triaged to a ward or to the ICU based on the severity of the bleeding, and they receive blood transfusions if appropriate. If they are on anticoagulants or antiplatelet agents, you hold these, you correct the coagulopathy if possible. Most patients then undergo colonoscopy, but this may potentially be deferred in patients whose bloody bowel movements have ceased at admission, particularly in patients who are not on and don't need to resume anticoagulation or antiplatelet agents. Colonoscopy is essential in patients with ongoing bleeding, and those who develop recurrent bleeding during observation, and those who need to be on anticoagulants or antiplatelet agents. I usually just place a nasogastric tube and rush in the go lightly over 2-3 hours. So typically these patients can be brought to colonoscopy within a 4-hour window. At endoscopy, if you see a clean-based ulcer or flat pigmented spot, no intervention is necessary. If you do see visible vessels, adherent clots, or active bleeding, these clearly need intervention. And again, this is usually with clip placement or thermal therapy with or without epinephrine. Some cautions here. The ulcer bed at the EMR site is often indurated if you're going in 2, 3, 4 days later, and clips and even the Coag rasper may be less effective in that scenario. You should consider using a contact thermal probe or an endoscope clip. For the rare situations where endotherapy fails, angioembolization can often happen. So here's a patient who presented with such a bleed to one of my GI colleagues at Stanford. Following a cecal resection, when he cleared up the clot, he found this ulcer bed with a potential visible vessel. He tried to deploy endoclips, and as you can see, these clips are lying by the side of the ulcer. They just failed to grasp the tissue, which, as you can see, looks very indurated, and they just kind of fell off. I was therefore in the next room, and he asked me to come in and see if I could place an endoscope clip. And that seemed to work quite well. So here we've got the clip being situated around the ulcer with a visible vessel. A little bit of light suction. You can see how indurated the tissue is. Normal tissue just gets sucked right in and you get it right out of your lens. This tissue is barely coming into your clip. The clip is then deployed. And the vessel is captured successfully. All right, so let's move on to perforations, which again for most endoscopists is the most field complication. You can minimize the risks of perforation and of bad outcomes following a perforation by some simple housekeeping rules. Ensure the bowel prep is excellent or good. If I'm doing a large EMR, I usually ask my patients to go through a 2-day bowel cleanout. That's very helpful in fixing bleeds and fixing perforations. If the cleanout is suboptimal, I will wash and suction the upstream colon thoroughly before I start my EMR. Again, we talked about CO2. You should really be using this if you're doing any number of large numbers of EMRs. Get an adequate submucosal lift. The other thing I do is close the snare quickly. So all the techs at Stanford know about the Banerjee hyperclose. And ask them to grasp the polyp. They kind of shut the snare, and this, they say, okay, it's closed off. And I say, no, hyperclose it. And they squeeze more until you can squeeze no more. And the tissue is very, very tightly bunched up. At this point, I stomp on the pedal, and this cuts through very quickly and very cleanly. The risk with rapid cutting is, of course, there's a slightly increased risk of bleeding, but I'd much rather deal with the bleed than deal with the perforation in a very large polyp. And finally, as we've talked about before, consider cold snake EMR, at least for smaller lesions. So when faced with the perforation that's occurred, the first thing to do is just to stay calm, right? Perforations at EMR are typically small and readily manageable. This is not like the huge lateral wall perforation made by a colonoscope. What you should do is position your patient and use suctioning to minimize spillage of stool through the perforation. So roll the patient so the perforation is not dependent. If it's a large perforation or one difficult area that you feel you have to struggle to close, and you have an anesthesiologist in the room administering MAC, consider conversion to intubation and general anesthesia to keep your patient comfortable. This should not, though, delay closure. And finally, ensure that there's no cardiorespiratory compromise. This usually occurs in the setting of attention pneumoperitoneum, which is extremely rare, once in a career kind of situation, where you have a ball valve effect where air leaves the lumen, can't re-enter it again. And this leads to massively distended abdomen with cardiorespiratory compromise. As can be seen from the X-ray here, there's elevation of the diaphragms and splinting. And this reduces lung volumes and impairs respiratory effort. There's also compression of intra-abdominal venous structures, including the inferior vena cava, which results in a drop in the cardiac output. So this is a medical emergency, which is best managed by insertion of an IV cannula into the peritoneal cavity. This can be done fairly rapidly, following application of antiseptic to the abdominal wall. And the local anesthetic is administered. This will be necessary for the patients under anesthesia. You can see the air flashback. An Endocut is then inserted, which allows escape of the pent-up air. And Dr. Rogers helping that along by squeezing the belly here. All right. So with the dangerous stuff off the table and out of the way, you have to then ask yourself, can endoscopic closure be accomplished, right? So this checklist should run through your mind. Is successful closure likely based on the perforation size and location? Are you familiar with deploying the chosen closure device? And finally, is this a non-contaminated perforation? And if the answer is yes to all of these, you can proceed. Now, for any GI perforation, size is the main determinant of your approach, which may range from conservative management for tiny pinhole perforation that's spontaneously sealing to surgery at the other extreme end for large tears that you can't manage endoscopically. By choosing a closure device, endoclips are great for small perforations, endoscope clips for larger ones approaching a centimeter to centimeter and a half, and for very large perforations, a suturing device is probably the best tool to use. As most EMR-related perforations are small and time is limited, I'm going to talk mostly about endoclip closure. The pros of endoclips is that they are, of course, readily available, easy to use. They can be advanced through the endoscope, so you don't need to remove the endoscope and reinsert it as you would have to with the endoscope clip or suturing device. Then rapid deployment is possible. The main cons are the restricted opening distance between the jaws, the lack of deep tissue closure, and overall low closure force. However, again, for the small perforations typically seen with EMR, they are very effective. Here's a video depicting a full thickness colonic perforation. It's on the fold, which is the riskiest site for polypectomy. You can see the so-called target sign here, indicating deep thermal injury. The nice thing about perforations on folds is that they're naturally approximated and very easy to close. Perforations on flat areas can be more challenging, but again, you know, most often these perforations are micro perforations, are very small. So here's another snare resection underway. And study the base of your resection sites closely. And again, you can see the nice kind of blue that you expect to see. When you start to see bits of brown and red, you know there's been muscle damage as well. And as you study the ulcer base closely, you can see there's a small microperforation just about there too. And so this is something that does need to be closed with endoclips. Basically, if you see any sign of muscle injury, redness or brownness in the base, you want to clip those patients too to prevent a delayed perforation. At the very least, to minimize risks of subsequent post-polypectomy syndrome advancing into full thickness perforation. Place your clips closely with a gap of no more than 1 millimeter or 2. Some tips for endoclip closure in the colon. Align the perforation to the pathway of your clips. For most colonoscopes, the clip emerges at around 5 o'clock, so you may want to have the perforation in the kind of left upper quadrant of the screen. A lot of these clips retract a little bit as you're deploying them, so just apply gentle forward pressure as you close them. And use a cap-fill EMRs. It not only helps with the EMR, it also helps you to separate clips as you're deploying these. Overall rates of closure perforations of clips are high, at around 90%. And this is in all closures. For EMR closures, it should be much higher, given the acuteness of the perforation and the small size of the perforations. Post-closure, close monitoring is necessary, as clip closure may be incomplete. and more than that, clip loss may occur. The patient will need IV fluids, broad-spectrum antibiotics, and bowel rest for at least a couple of days. You should follow patients to the surgeon and consider surgery if tachycardia, fever, or leukocytosis develop. If the patient develops diffuse peritoneal signs, or if a CT abdo shows extramural fluid and debris, indicating a persistent leak. When should you throw in the endotherapy towel and call in your surgeon? For large perforations with poor endoscopic access, where endotherapy fails, of course. Patients showing clinical deterioration during observation, where there's clear-cut fecal peritoneal contamination, and when there's a large residual polyp, which is going to be now difficult to resect after you've employed endotherapy and closure in that area. In this situation, surgery removes the polyp and the problem as well. So I'll stop here and take any questions. Thank you.
Thank you so much, Dr. Banerjee. A couple of questions. I have become a proponent of piecemeal cold snare, particularly for like duodenal EMR due to the low risk for perforation and delayed bleeding. But the one thing that seems to complicate it is that kind of you can have immediate bleeding that kind of makes the visualization of the resection site difficult. Do you have any tips for kind of maintaining good visualization while to complete the cold snare piecemeal polypectomy?
Yeah, when I do cold snare, I usually use epinephrine mixed with my Endocut, 100,000. That's the key thing that helps. For colonic perforation, colonic EMRs, I've kind of more or less gone over to using pre-made solutions, which are commercially available. So I tend not to use epinephrine for the colon. The colon also tends to bleed much less than the duodenal nose, as you know.
Yeah.
So I think epinephrine is the answer. It's not ideal, but it's the only thing we have right now.
Got it. And then in approaching these really large polyps and practically doing many more procedures at ASCs or kind of endoscopic centers that are not attached to a hospital or an emergency room, do you feel that there are certain procedures that just shouldn't be done away from a hospital or surgeon around?
I think it depends on your skill set. You know, I think any perforations are so rare, and they tend to be micro perforations, and they're almost always fixable with endoscopic clips. And again, the bleeding intra-procedural is not particularly severe, typically can be managed very easily. So I'm not opposed to doing EMRs and ASCs. And in fact, a very long time ago, we had an ASC attached to Stanford, where I did do my EMRs as well. So that does not stop me. If the patient is high risk for other reasons, you know, because significant comorbidities, elderly patient with multiple comorbidities, he's stopped his anticoagulation a few days ahead, maybe that's the kind of patient you want to do in the hospital. But it's more patient factors that would sway me rather than just the EMR itself.
Great. And for lesions that are quite large, like 40% circumferential, 50% circumferential, that you just can't close to reduce the risk of post-polypectomy bleeding, do you have any strategies, maybe like targeted clipping of high-risk vessels or coagulation of high-risk vessels where you just can't get complete polypectomy closure?
Right, and that's very common, particularly in lesions larger than 4 centimeters. And most of the studies show that closure of these is incomplete. And to your point, that's exactly what I do. I close what I can. If there are vessels that are clearly visible in the submucosa, I'll clip over them as well, minimize that risk.
Great. And then I think the last question is resuming anticoagulation or antiplatelet therapy after EMR. Some recent studies have suggested that it's pretty much safe to resume things like Pradaxa, like the day of the procedure, if you've achieved closure. But do you kind of have certain guidelines that you follow or just certain things you do as far as timing of resuming anticoagulation?
Again, it comes down to the patient. And my philosophy all through and before the data was available was that most patients on anticoagulation to prevent either MIs or strokes, and both of these events are catastrophic. The bleed you can usually fix. So unless the patient is somebody who, lives in a very remote area where he can't get access to medical help, or has such bad comorbidities that a bleed would be really harmful to them, I usually let them start the anticoagulation if I have a cheap clip closure.
Gotcha. And then you just give them very strict instructions as far as what to look for post-polypectomy bleeding and a low threshold to come back.
Head to a hospital, and but again, you have to weigh out the catastrophic effects of a stroke or MI versus a bleed, which by and large a lot of them will fix themselves. The ones that don't, you don't need to fix them very readily.
Great. Well, thank you so much for speaking today.